Just a little bit, yeah. A little better. All right. So we're going to do medication management and medical appointments today. So it's kind of a mishmash. And when I was putting it together, I realized it was just a lot of um, information that I think you all need in learning how to navigate the healthcare system. Okay. So first of all, I'm Catherine McDermott. I'm a psychiatric mental health nurse practitioner. I'm a co-owner here at Town Square. I think many of you know me, but welcome and thank you for coming. Hopefully we'll get through this in about 40, 45 minutes, and then that leaves time for questions at the end if you have them. Okay. So the first thing we're going to talk about is person-centered care. Now, there's a lot of talk about person-centered care, but person-centered care is really where it's not one size fits all, right? We really look at the individual, what their needs are, and you should have, now I'm going to talk about what you should have and what's actually out there. You should have a relationship with your healthcare provider where you can discuss what your issues are, what your concerns are, and you can be heard, okay? You may not get the healthcare provider to agree with you, or they may have different ideas about how the best way is to care for your loved one, but you should be able to at least discuss what those thoughts are. And then the care plan should be tailored to what that person's needs are. And so that's really when we talk about person-centered care. We do that here at Town Square. When we do our care plan conferences with you folks, we learn about our members. We find out what are their pluses, what are their minuses, what are their triggers, what makes them happy, what makes them unhappy, so that we can develop that plan of care, right? I have many patients who are like, I don't want to be on any medications. Okay, well, let me give you the options. We can talk about that. Maybe that's a positive for you, maybe it's a negative, and maybe if I can give you some scientific information and background about it, it might change your thought process, right? But it might not be the first thing I'm going to recommend to you because I know that's not something that you're interested in doing, okay? So that's when we talk about person-centered care. That's what we're talking about, okay? All right, let's talk about the people in our healthcare network and who do we start with? So when people say to me, I'm starting to have a hard time with my memory, what's the first thing I should do? We tell you the first thing you should do is go see your primary care provider. Why? Because there are reversible reasons for why people are having trouble with their memory. They can have a low vitamin B12, they can have a thyroid disorder, they could be developing diabetes and not even realize that their high blood sugar is what makes them feel foggy and unable to concentrate and focus. So the person who starts and should be our primary person who we'll go to first is that primary care provider. It is their job to do a physical examination, check routine labs, and then rule out any of those other things and say, nope, we need to send you on to a specialist, whether it's for your memory or for your thyroid, for your arthritis, whatever it is. The primary care provider is that gatekeeper, that person who sort of is the one you come to first and they move things along for you, okay? Having a good relationship with your primary care provider is extremely important, okay? This is that person who's really should be able to listen to you and help you make those decisions for yourself. Neurologists. How many of us have seen a neurologist? Okay. How many of us love neurologists? Okay. One of the biggest issues I find with people with neurologists is that their expectation of what the neurologist is supposed to do doesn't meet what the patient thinks the neurologist is supposed to do. So the first thing I'm going to say is I love neurologists because they help me make the diagnosis. They rule out that there's something organic or structurally wrong with my patient's brains. Do they have a brain tumor? Do they have normal pressure hydrocephalus? Have they had a stroke that nobody knew about and is now impacting their memory, right? So when I send my patients to the neurologist, I expect the neurologist to do a neurologic workup. Their job is to know the brain and the disorders of the brain, right? Their job is diagnosis. So they do that MRI, they do that CAT scan, they do the lab work, and you come back in and they say, your loved one has dementia most consistent with vascular, Alzheimer's, Lewy body, frontal temporal lobe. It is their job to give you that information. It is not their job to treat that. They treat the dementia in terms of dementia medication. So they may be the one who gives you that first prescription for Aricept or memantine, right? Because those are the medications that we use in order to try to slow down dementia. Now, in light of the new monoclonal antibody injections, they may also say to you, hey, we have a research study or we have a new division for memory care in which your loved one could be evaluated for some of these new medications that will decrease the amount of amyloid plaques in their brain, right? So they're going to send you on to that. They are not going to spend an hour with you explaining what dementia is, talking to you about what stage your loved one is in, talking about the psychological and psychiatric issues that go along with dementia, okay? And they're probably not going to send you out of their office with very many resources. It's not their job. So we have to remember that as much as we're disappointed sometimes when we see the neurologist, we have to understand the expectations of what their job is, what they're supposed to do. Now, sometimes it's not always easy for the neurologist to make that diagnosis based on imaging and lab work. Sometimes the person we really need is the neuropsychologist. The neuropsychologist is not a medical doctor, which is why they work with the neurologists, right? So the neurologist sees you, rules out any organic reason, brain tumor, normal pressure, hydrocephalus, stroke, sends you to the neuropsychologist. That's okay. And the neuropsychologist sits you down and does 4 hours of testing with you. Long time, okay? The neuropsychologist is looking at all the different domains that we look at when we talk about cognition. And we've talked about this before, right? Cognition is not just short-term memory loss, right? It is long-term, short-term, auditory processing, visual processing, sequencing, executive function, right? There are multiple different domains. What domain you are having a deficit in will help the neuropsychologist determine the type of dementia you have and what stage. Is this mild, is it moderate, or is it severe, okay? Typically, by the time you get to severe, you're not going to make it through the 4 hours of the neurocognitive testing. But mild and moderate can, and that information can be very useful to us. Okay, so people say, well, why? How is that helpful to me if I know that your deficit is in auditory processing, Pat, right? So I find out, Pat, I can walk up to her and give her a command. Can you come in the kitchen with me and we're going to set the table? And she sits there and looks at me. But I can write it down on a piece of paper and she can read it and she gets right up and comes along. Because the area of her brain that processes auditory information is damaged. Well, that's really important for me to know because if the part of her brain that's damaged is visual processing and I put notes all over the house, is that going to be really helpful? So understanding sequencing. Sometimes if they're unable to process things in a certain order and we give a person with dementia multiple steps in a certain sequence and they can't do it because they can't follow a sequence, that's important information for us to know, okay? The type of dementia is also very important for us to know. So the combination of the neurologist and the neuropsychologist should be able to give you that information, okay? Does that make sense? Okay, any questions so far? How are we doing? Good, all right. Psychiatrists, psychiatric mental health nurse practitioners. It is our job to treat the psychiatric symptoms of dementia. What are the psychiatric symptoms of dementia? What do you think? What do we talk about? Anxiety, depression, correct. Motor restlessness, insomnia, These are all the psychiatric symptoms that go along with dementia. There's also delusions, paranoia, hallucinations. Now, I'm going to go back to the neurologist for a minute. Many neurologists are double board certified in both neurology and psychiatry. So many of them understand this piece of it. But if they're working as a neurologist, chances are they're not doing a lot of psychiatry. Now, they may, if you come to them and say, hey, I went to my primary and he's not comfortable writing these prescriptions and my husband's having terrible anxiety and depression, the neurologist may say, well, I can treat that for you and write medication for it. And some of them will, some of them won't. But again, it depends on the certification and the background of that neurologist, okay? Many times they will recommend that you see a psychiatric provider. Psychiatric providers that deal with geriatric psychiatric issues in Florida are rare, which was very shocking to me when I first moved down here, given the fact of the population that we serve here, right? I mean, this is a population that is typically has issues with cognition and the psychiatric issues that go along with it. But finding a provider is oftentimes very difficult. So it falls back on the neurologist, it falls back on the primary care provider, okay? But that is the role of the psychiatrist, all right? All right, questions with that? Psychologist. Now, this is always an interesting one for me because a psychologist, again, very much like the neuropsychologist. So the neuropsychologist is a psychologist who's gone on and had additional training in studies of the brain, right? And has to do more with cognition. And again, remember, neuropsychologists don't just evaluate for dementia. They're the person that the kids go to when somebody thinks they're autistic or when they have a learning disability. Their job is to evaluate and diagnose all of those types of things. So some neuropsychologists are not as in tune with the dementia stuff because they typically work with children. And again, these are all specialties and areas that providers will go into based on what area they are interested in. Psychologists are, again, not medical doctors. They have no medical training. Their training is strictly in how the brain works and in emotions and thoughts and behaviors. When you go see a psychologist, they do not write prescriptions. They do talk therapy or other types of therapies that will help you deal with whatever the psychiatric issue is that you're having, whether it's marital issues, whether it's anxiety, whether it's depression, whether it's bipolar, whatever the psychiatric issue is, the psychologist's job is to develop a plan of care and a treatment with you that augments the medication that you're being given by the psychiatrist. So let's go back to that for a second. A lot of times people come into their primary care and they say, I'm feeling really depressed. And the primary care, and I don't want to go see a psychiatrist. And the primary care says, okay, I'll put you on medication. They write you a prescription for an antidepressant and send you out. The way that's really supposed to work is that you're then supposed to schedule an appointment with a psychologist and try to figure out what the underlying trigger, thought pattern, or process is that's causing you to feel depressed. The pill is not the only answer. It's going to help. But the gold standard is that not only are you treated by the psychiatrist, but you're also treated by the psychologist, who then can help you with those thoughts and feelings that you're having so you can learn how to deal with those, maybe change your thought process, maybe reframe things that are happening in your life so that it's easier for you to feel better on the medication that you're taking from the primary care provider, okay? So psychologists can be very helpful in our life in many different times, at times of loss, at times of emotional distress, at major life events that are either positive or negative. Stress doesn't always have to be from a negative event. Planning a wedding is incredibly stressful. It's a positive thing, but people can have increased anxiety and depression and agitation around positively stressful events as well. That's where psychologists come into. Okay. All right, social workers. So social workers are also an interesting breed. Social workers can be clinical, so you can have a licensed clinical social worker. A licensed clinical social worker also does therapy. And oftentimes they sort of blend again that idea of therapy with treatment and interventions that they can do. Social workers are often people who find resources for you. If you are dealing with substance abuse, that licensed clinical social worker is going to do therapy with you, but she's also going to be the one who's going to figure out where the local resources are for you as you're dealing with whether it's alcoholism or drug addiction or whatever the issue might be, dealing with caring for a family member who has dementia. They're the ones who are going to help you find town squares and places that are helpful for you in terms of resources. So they're similar to a psychologist. They don't have the educational level as a psychologist, but they're also often people that will help with resources. Most of the hospitals have case managers who are social workers. The entire job is to help people who come into the hospital to find resources, to make sure that they're hooked in with whatever they need in terms of resources for whatever their medical problem happens to be. Okay, social workers are very rare. There were some psychiatric mental health nurse practitioners or psychiatrists. I mean, there's a lot of them out there, but there's so much need in so many different places, and they oftentimes these positions are not filled fully. Like in the hospitals, you might have 3 social workers that are doing the job of 6 or 7, and it can be very difficult to manage all of that. Okay. All right. So who do you need on your team? So you have to pick your team for your person-centered care, and you need to make sure that all your team members know who everybody is, right? You don't want to be going to the neurologist and be going to the psychiatrist, and the neurologist is writing psych meds, and the primary care is writing psych meds, and the psychiatrist is writing psych meds. I had a gentleman today I saw in my assisted living facility. He goes to the neurologist for his Parkinson, and while he was there, he happened to mention that he was feeling depressed. Now he's already on bupropion, which is Wellbutrin, an antidepressant. He's on duloxetine, which is also an antidepressant. He's on Seroquel, which is an antipsychotic for his hallucinations. He's on trazodone for sleep. He's on pamiprexol, which is for restless legs, but also has a psychoactive effect to it. And he's on Xanax, PRN, for anxiety. And the PA at the neurologist's office decided to increase his bupropion from 150 milligrams to 300 milligrams. So I went to see him today. I said, Todd, how you feeling? A little jittery. Gee, you think? I said, did she know all of these meds were on? Well, I think so. Not sure she did. So again, it's very important that you share that information. I have a psychiatrist who's writing my psychiatric meds. You're my neurologist. I have Parkinson's. You take care of my Parkinson's. And sometimes it's a difficult conversation, right? Because they want to tell you what they think or what they think is. You could say thank you very much, but you pick who the members are of your team, right? And you decide, as many of you have, once the diagnosis has been made with the dementia, and the neurologist really doesn't have a lot more in terms of things to help you with the disease, that you've moved on to the psychiatric provider and perhaps the psychologist, and those are the people who are going to be part of your team. Just because you start with them doesn't mean they have to stay with you. They have their role. The neurologist is very important in making that diagnosis for you, but once they've done that, then sometimes their role has sort of run its course. Okay? And some people say, well, I go back every 6 months and they do the same test and they go, yep, he's declining. But that's not really helpful, right? So not really sure how necessary that is always. All right. We're going to talk about, so that's the medication, or the medical appointments, the management of sort of navigating your healthcare team. Does anybody have any questions about that? Okay. We're going to talk about something that's very near and dear to my heart, which is polypharmacy. And this is, one of the things we just talked about today, actually, in our managers meeting, is that one of the things that we need to know about all of the members here at Town Square is what medications they are on. It's very important. You go to your primary and he says, oh, gee, blood pressure is elevated. We're going to go up on this dose. Then they come to Town Square and they're a little dizzy and we don't know that you've changed their medication. And now all of a sudden, you know, our member's looking a little peaked and can't stand up as quickly and, is falling over. And we don't know that there's been a change in medication. It's very important for us to know, is there a new diagnosis? Has there been a fall? Have they gone to the hospital? Have they started a new medication? So that we can be aware of it and we can manage it. Should we notice that, gee, he stood up quickly and his blood pressure bottomed out and he got lightheaded, I want to call and tell you that that happened so that you can call your primary care provider and let them know, and we can manage that. We're not a medical community here. We're a day center, right? But we do have medical people. We have our nursing students, we have Tara, we have myself that are overseeing the medical care of everyone here, and we need to know that information. One of the things that happens, as we just talked about, is you go see the cardiologist and he puts you on this medication. You go see the primary care, he puts you on that medicine. You go see the neurologist, who puts you on this medication. And by the time you come home, you have a list of medicines that's this long. And when you go to the pharmacy, the pharmacist goes like this, because this one interacts with that one, and this one is for the side effect of that one, and now you've got this huge list of medication. So polypharmacy is defined as 5 or more medications. Now think about your loved one. How many meds is your loved one on? 5 is not a lot of medicine. So again, you have to advocate for yourself. You have to advocate for your loved one. Do we really need to start a new medicine? And if we are starting a new medicine, is there something that we can take away, right? And as a provider and a clinician, I try very hard not to write a medication for a side effect of another medication. One of the classic examples of this is patients with Parkinson's disease, because very often they're on medication to help boost their dopamine levels, because that's something that they have very little of. But sometimes that can worsen their hallucinations and delusions. Then we put them on a medication that decreases their dopamine. So they're kind of working against each other. So, but you want to make sure that all of those specialists know each other and know that what they're on. So when they tell you to bring the bag of pills, bring the bag of pills. They tell you to write it out so that you know, and remember to tell them everything that's on there, because it's very important, because we don't realize how many of those medications can work against each other and then cause a problem. Major risks, falls and fractures. Number one risk of polypharmacy. Second is hospitalizations. If you are taking a medication that lowers your potassium, but then you're also taking potassium, and you stop taking a medication for the potassium, now all of a sudden your potassium goes through the roof, hospitalization, right? Cognitive decline. And this is one of the things that happened in the assisted living facilities that was really shocking to me. I remember we'd have a patient who was declining and declining. We'd go to the family and we'd say, it's really time for you to consider hospice services. The family would agonize and decide, yes, it was the right thing to do, and get the person signed up for hospice. And the hospice doc would come in and go, oh no, just continue this, just continue this, just continue this. We got the person down to 2 or 3 meds. 3 days later, they popped up like a daisy. They were walking, they were talking better, they started eating again. Hospice cured them. Hospice took the initiative to really say, do you really need all these medications? And we're sort of at that point where we can say, well, we can take these away and see what happens, because we're prepared that the person declines to say the person's going to decline. But a lot of times, it was getting rid of the medications that actually made the person better. So cognitive decline, mortality, right? And we talked a little bit about that. And then adverse events, because meds interact with other meds and people will have a reaction. I've had people have seizures. I've had people have blood clots. I've had people have all kinds of crazy adverse reactions when you put 2 medications together that really shouldn't be together, because there's risks of those things. Okay. We're going to talk about palliative care, and we're going to talk about hospice care. Does anybody know the difference between palliative care and hospice care? Or do you know what either one of them are? Okay, all right, so let's talk about this. So palliative care is active holistic care of an individual, but it is not treatment per se, okay? So when you have somebody who has made the decision to go more with palliative care, we're talking about treating the whole person, but not necessarily treating certain chronic illnesses or staying on the dementia meds or staying on the high cholesterol medications. Again, trying to get that polypharmacy down some, right? We're going to basically say we understand these are chronic illnesses. There are no treatment for them. And we're not going to treat them. We're going to go more with a holistic, let the disease take its course. Okay? That's palliative care. Now, that doesn't mean if you get pneumonia, I'm not going to write you an antibiotic. Pneumonia is treatable. I'm going to treat that. But if your blood sugar is elevated and your hemoglobin A1C is slightly elevated, I may say, let's not put you on an insulin or a diabetes medication because it's very mild and there's risks to those medications, and we're just going to let the disease take its course. That's a palliative approach. And the cornerstone of palliative is quality, not quantity, right? Because, and this happens a lot of times with folks that get diagnosed with cancer, and the cancer is a terminal cancer. And they go and they say, well, should we do chemo? Well, the chemo is going to make them terribly sick, and the quality of their life is going to decline, and it's not necessarily going to benefit in terms of quantity of life. It's not going to prolong their life, but they're going to be miserable for however much time they have left. And nobody really wants that, knowing that the illness is terminal. All right. So we talk about hospice. Hospice, though, is the next step from palliative care. When we move into hospice care, what we're basically saying is our best educated clinical guess is that you have 6 months to live, approximately, right? And this is where we not only take that palliative approach of not treating chronic illnesses, but we may actually use medications that are for comfort, but are not necessarily good for you medications. In other words, are they pushing the disease state along a little bit? And again, we don't practice euthanasia in this country, at least not in this state. There are some states that you can, if you've decided prior to having whatever, that if you have a terminal illness that you want to end your life, and there are some states that do allow that. But that's not what hospice is. Hospice is, I'm at the end of my life. I want to be comfortable. I know that these medications may not be good for me long term, but I'm willing to take them because they're going to give me comfort. They're going to decrease my pain, whether it's emotional pain, whether it's physical pain. We use a lot of antipsychotic medication in dementia patients at the end because we want to decrease their delusions and their paranoia because they're emotionally distressed. And emotional distress is just as important as physical distress, right? And we want to make sure that those people are comfortable. We know that those meds are not good long term, but we're not looking at long term. We're looking at several months to maybe 6 months, and we want them to be comfortable so that they can end their life comfortable. Okay? And that's what I got for you guys today. I feel like I ran through that one. Questions? Mm-hmm. So they should, is that something that you should do instead? It's a good question. So what Mary's asking is if you have a question about your medication, she was always told go ask the pharmacist, not necessarily your doctor. So it is and it isn't. So let's talk about that a little bit. So as clinicians, we write medications for what they're indicated for. Sometimes we write medication what we call off-label, right? So there's a really good example of this medication is gabapentin. So gabapentin is indicated, it's FDA approved for neuropathy, pain in our legs and our fingers, typically from diabetes or some other neurologic